Welcome to the EUROGEN webinar programme. Just before we get started, I would like to take a couple of minutes to explain a little bit about what a European reference network is and does. EUROGEN is one of the 24 European reference networks, all covering different medical fields. They were created by the European Commission in 2017. And they all deal with patients with rare diseases or complex conditions that need highly specialised surgery or healthcare. The aim for us as a network is to try to deliver faster specialist evaluation, more equitable access to high quality diagnosis, treatment and care for all those patients with a rare urorectogenital disease or complex condition that needs highly specialised surgery. So what do? Well, within the network, we collaborate through a clinical patient management system, which gives us the ability to conduct a secure, virtual, European level MDT between the specialist centres in our network, so that we can give advice to any healthcare professional working in any hospital across the EU who needs advice on a patient with a rare disease or complex condition. We also collaborate in education and training, such as these webinars, and we also have a clinical exchange programme so that we can exchange trainees between our various hospitals. And finally, we're working on building a registry, so this is very exciting. Very soon, all 24 ERNs will have an operational registry, so we'll be collecting all the data related to patients with rare diseases, so we can really benefit from the economies of scale of working at European level. So that's enough about the ERNs. Today's webinar is in collaboration with the Anorectal Malformation Network Consortium, who are very dear supporting partners of the ERN. And so without further ado, so the topic of tonight's webinar is surgical management of total colonic aganglionosis. And I'm really delighted to introduce Professor Mikko Pakarinen, who is Professor of Pediatric Surgery and Head of Department at the Children's Hospital in Helsinki, Finland. And then we also, again, a very warm welcome to Tomas. Thank you so much for doing this. And he will follow on after Mikko. And he's Professor of Pediatric Surgery in Stockholm. So thank you both so much for sharing your expertise and knowledge with us, and I'll give you the floor, Mikko.
Okay, thank you very much for your introduction. It's a great pleasure and honor to give this talk on total colonic aganglionosis within joint webinar of EUROGEN, ERNICA and UPSA. And of course, I would like to also express my support and sympathy for all the Ukrainian people who are struggling in very unfair and unfortunate situation. These are my disclosures. The incidence of TCA is a quite rare disease with the incidence of 1 to 50 to 100,000 live births. So about 5% of all Hirschsprung's disease patients end up to have TCA. And from the very beginning, it's quite important to realize that the small intestinal extension of aganglionosis among these patients varies a lot. In this table, you see the distribution of intestinal extension of aganglionosis among 94 patients from a Nordic multi-center study. And as you can see, in that study, about 75% of the patients, the aganglionosis was limited within 20 centimeters of distal ileum. On the other hand, about 16% of these patients had a quite extended aganglionosis beyond 50 centimeters of distal small intestine. It's also important to realize, also considering the surgical treatment, that these patients have frequent comorbidity. And among 108 TCA patients from the same Nordic study, about 30% of of the patients had any comorbidity, and importantly, about 20% of them had a syndrome and or genetic mutation, which may greatly affect the functional expectations of surgical treatment. About 20% had some other developmental malformation, and another 10% of some other form of concomitant disease. What are the key issues to consider before definitive surgery among these patients? The first and foremost is, of course, the exact level of aganglionosis, because this will dictate all the further surgical treatment. And as I said, it's also very important to consider possible associated syndromes and genetic mutations such as Down's syndrome, or, for example, in Finland, cartilage hair hypoplasia is quite common among these patients, and they may greatly affect the functional expectations. Then one have to consider whether the patient is suitable for a pull-through, or should we go for a permanent jejunostomy? And if you are going for a pull-through, what type of pull-through procedure should you do? And if you go for jejunostomy, should it be combined with Ziegler type, myectomy, or some other type of autologous intestinal reconstruction surgery? And of course, what is the optimal timing of all these procedures, and when should we remove the aganglionic bowel parts? Like I said, establishing the exact level of aganglionosis is a paramount importance in these patients. And of course, there are many clinical scenarios when these patients end up in OR, but most commonly it's a clinical suspicion of distal obstruction. And it's very rarely that these patients must be operated during on-call hours. So this is an operation which should be done during office hours, and importantly, with an experienced pathologist involved. And the safest way is to obtain full thickness frozen sections and formalin embedded intestinal biopsies about 20 centimeters apart from the rectum to ligament of Treitz, because any macroscopic caliber changes or possible findings in contrast studies are very unreliable in case of a small intestinal aganglionosis. Having said this, we have done in our series half of the pull-throughs based on frozen sections, but as I said, this is the safest way to proceed. This operation is usually completed with performing decompressing loop enterostomy, the level of which is guided by frozen sections. And if you are in a situation where you don't have the frozen section information, the safest level is probably in somewhere in the distal ileum. And then the full immunohistochemical assessment of biopsies should be completed, and repeat or additional biopsies obtained if necessary. And it's important to emphasize that pull-through or any definitive enterostomy or any intestinal resections should be performed only after the level of aganglionosis is confirmed. So there are also some issues which should be considered when you're thinking about whether the patient is suitable for pull-through or should you go for jejunostomy. And the main issues are probably that, is the remaining small bowel length technically feasible for pull-through? On the other words, is the small bowel long enough to reach perineum? And also very important is the question is that is absorption from the remaining small intestine efficient enough to avoid persistent debilitating diarrhea, perianal rash, and prolonged dependency on parenteral support after pull-through? And I think it's very important to have realistic expectation and to give realistic parenteral information on functional outcome expectations in these patients. Now, just to give you some background how to choose the patients for pull-through, this slide shows the Helsinki experience among 29 patients. 17 of them had aganglionosis which extended or was limited to less than 50 centimeters in the distal ileum. All of these patients underwent pull-through, and none of them had any major subsequent surgery, and all of them weaned off parenteral support. And the situation is very different when you compare the patients in whom the aganglionosis extended beyond 50 centimeters. Among those patients, only 25% of them underwent pull-through, and only 2 of them weaned off parenteral support, and both only after intestinal transplantation. And very similar experience was very recently reported from Paris Necker, and they compared their experience in patients who had ganglionic proximal small bowel more than 1 meter remaining to those with less than 80 centimeters. And among those patients who had more than 1 meter of proximal ganglionic small bowel remaining, all of them underwent pull-through, and 90% of them had been weaned off parenteral support. And very similar to Helsinki data, only 2 of those patients with more extended disease underwent pull-through, and only 1 of them weaned off parenteral support, and that patient also after intestinal transplantation. So if you look at the combined experience of these 2 studies from Helsinki and Paris, among patients with TCA, all 26 patients with less than 50 centimeters of aganglionic distal small bowel or more than 1 meter of aganglionic small bowel proximally underwent pull-through, and basically all of them weaned off PN. And in contrast, none of the 27 patients with more than 50% of distal aganglionic small bowel or less than 80 centimeters of ganglionic proximal small bowel weaned off PN without intestinal transplantation. So if you go for pull-through, what type of pull-through should you do? There is no strong evidence for superiority of any of the pull-through techniques. And this table just shows you some data from the multicenter Nordic study, where we compared the functional bowel function after different procedures. And as you can see, there was no significant differences among different type of pull-throughs, although the numeric bowel function score was highest after J-pouch ileoanal anastomosis. And interestingly, also these patients were also much more frequently reported always to be able to hold back a defecation when compared to other groups. So why we perform J-pouch ileoanal anastomosis in Helsinki? And there are several reasons for that. It's an operation which is feasible at any age. You can do it even in a neonatal period. We think that the functional outcomes are long-term functional outcomes are quite reassuring, but probably most importantly, we have decades of experience doing basically the same operation in all other patients with Hirschsprung's disease as well, and also in teenagers with ulcerative colitis. So we're quite familiar with the surgical technique and possible problems, complications, and also functional expectations. So in this respect, I think that it's probably wise to do the same operation for TCA, what people are using for other types of Hirschsprung's disease. So we do J-pouch ileoanal anastomosis among those patients who, as term newborns, have less than 50 centimeters of ileal aganglionosis. And the operation involves removal of ganglionic colon and distal small aganglionic colon and distal small intestine, creation of short 3 to 5 centimeters J-pouch using an endostapler. Sometimes it's necessary to divide branches of ileocolic artery in order to reach perineum without undue tension. We have used both abdominal and transanal mucosectomy combined with split or short muscle cuff. And we'll always perform hand-sewn ileal anastomosis in these patients. And we also use covering ileostomy, which is closed about 3 months after the operation, after performing contrast study and pouch endoscopy. A few words about our post-operative management. We follow up these patients every 3 months until the age of 1 year, and then twice or once a year, usually depending on the clinical situation, until adulthood, followed by transition. All these patients are transitioned to adult care. And it's very important to have also gastroenterologists and nutritionists closely involved with the follow-up. As when it comes to nutrition, of course, we follow up growth and also levels of B12 and fat-soluble vitamins, because the ileal resection predisposes to these deficiencies. They should be surveyed and supplemented if needed. Bowel function is related to sometimes, especially early, with the perianal irritation, obstructive symptoms, enterocolitis, bowel function frequency, and of course follow-up of development of continence, which is not usually a not very big issue. We also follow fecal calprotectin and perform pouch endoscopies in these patients due to increased risk of IBD. We also use routinely sodium chloride supplementation in order to reduce the fecal water content. I have to say that obstructive defecation and enterocolitis is quite common, especially during the first post-operative years. And in these situations, we use intrasphincteric sphincteric Botox injections with a low threshold. And in the figure, you can see the development of bowel motions per 24 hours among these patients. And 6 months after stoma closure is quite high, but comes down in 2 years in the median frequency of 3.5. So when do we do this procedure? To assess this, I have divided our patients into those who had less than 20 centimeters of ileal resection compared to those who had ileal resection close to 40 to 50 centimeters. And among those with very limited small intestinal extension, they underwent pull-through at median age of 2 months, and stoma was closed at median age of 6 months. So based on this, none of these patients required prolonged parenteral support. So maybe in these patients, the age what we currently use is about 3 months or so. But it's quite different the situation among those patients who have more extended ileal aganglionosis. Among those patients, the median pull-through age was 18 months, and 2 of these patients required prolonged parenteral support, median of 22 months. So in these patients, I would probably wait for until about 2 years, at least for the stoma closure, or use the stoma output less than 30 milliliters kilogram per day as a limit before the pull-through, as was reported by the Paris experience, which I mentioned before in this presentation. So I mentioned that we think that our functional outcomes are reassuring, and this slide just shows you the sort of main outcomes within our patients who underwent pull-through. Among those patients who had less than 50 centimeters of ileum resected at median age of 10 years, 14 of them had voluntary bowel movements, 2 of them needed rectal tube decompressions. 14 of the 15 patients who were above 3 years of age had no major issues with fecal continence. None of them used any protective aids or so. 3 of them are having repeated Botox injections. None of them have enterostomy, and 1 of these patients required parenteral support later on after developing very severe generalized dysmotility, which I don't think has much to do with the surgical technique used. But these results are very different to the 3 patients who underwent pull-through but who had aganglionosis which extended beyond 50 centimeters. 1 of them died due to severe enterocolitis, and 2 survivors are both on parenteral support, and 1 of them being transferred to permanent enterostomy. And to be honest, in retrospect, I think all these 3 patients would have done much better should we have chosen primary permanent jejunostomy as a surgical treatment. So we do jejunostomy on those patients who, as term newborns, have less than 80 centimeters of ganglionic proximal small bowel left. And depending on the level of aganglionosis, a jejunostomy is performed at minimum of 50 to 80 centimeters distal to ligament of trides, despite leaving some aganglionic jejunum in continuity. And this is to avoid high output enterostomy and also to protect liver and to maintain abdominal domain should the intestinal transplantation become necessary later on. And if there's persistent obstructive symptoms or stomal hypersecretion, undelay, or we consider a longitudinal Ziegler type of myectomy of a ganglionic segment. And this is to obtain unobstructed bowel function to promote normal eating and enteral nutrition, which is persequent for subsequent therapy with teduglutide, which is available from the age of 1 year beyond. Just to give you some figures about the actual level of jejunostomy we have used in these patients. Among 7 patients who were primarily operated in Helsinki, in patients who had less than 50 centimeters of ganglionic proximal jejunum left. The average length of ganglionic jejunum in these 7 patients was 11 centimeters, and we left in average of 60 centimeters of proximal jejunum in situ. 2 of them underwent subsequently myectomy. None of them have had progressive intestinal failure associated liver disease. 2 of them, as I mentioned, have received intestinal transplantation, and currently 2 of them are on teduglutide, and 1 of them have basically weaned off parenteral support on that therapy. So when should we remove the aganglionic colon and small bowel among those patients who receive a jejunostomy? And this is important to prevent enterocolitis and associated bowel-derived sepsis episodes, and by doing that also to protect liver function. And according to recent Paris experience, in their material, 59% of enterocolitis episodes occurred in excluded aganglionic bowel at median age of 2.8 years. So based on this, I would say that the unused aganglionic bowel should be probably moved by age of 2 years. It's also possible to perform further autologous intestinal reconstruction surgery of aganglionic bowel, such as a transposition of myectomized ileum, little tapering, etc. But it has to be said that these procedures are very few reported. They are experimental in nature, and in my opinion should be performed only in very highly expert centers. And it should be also emphasized that of the 27 patients I showed treated in Paris and Helsinki with very extended aganglionosis, so that these patients only had less than 1 meter of proximal ganglionic small bowel left. Of these 27 patients, none weaned off parenteral support, and 7 were transplanted. So it's very obvious that early contact and cooperation with the expert intestinal failure unit and transplantation unit should be started too early to optimize central venous catheter care and also liver protection, and optimize the treatment all the possible ways. So just as a summary and take-home message, in those patients with the total colonic aganglionosis, the most important thing is to establish the exact level of aganglionosis. And among those patients with less than 50 centimeters of aganglionic distal ileum or more than 1 meter of ganglionic small bowel, proximal small bowel remaining, those patients most likely are suitable for endorectal pull-through. On the other hand, those patients with less than 80 centimeters of ganglionic proximal small bowel remaining, when those patients are treated, I think it's valuable to start early collaboration with expert and transplantation center. Then those patients undergo a proximal jejunostomy, 40 to 80 centimeters distal to ligament of Treitz. And if these patients develop further symptoms, subsequent myectomy may be considered. Also teduglutide, possibly other autologous intestinal reconstruction surgery. And we should also remember to remove the unused aganglion bowel probably by the age of 2 years. And thank you very much. I'm very happy to take any questions after Tomas has given his presentation. Thank you.
So thank you very much, Mikko. I would also like to thank EUROGEN for inviting me to talk about the long-term outcomes of total colonic aganglionosis. And like Mikko, I would really also like to express my concern and my sympathy with the Ukrainian people. I have no conflicts of interest. And when it comes to total colonic aganglionosis, it is often defined as aganglionosis including the colon and the ileum beyond the ileocecal valve, including up to 50 centimeters of small bowel. And I think it's important to remember this, reading papers on outcome of total colonic aganglionosis, because some publications include this group of patients, and other publications include also patients with aganglionosis extended further up into the ileum. And as Mikko described, those patients have a worse long-term outcome. Total colonic aganglionosis occurs in approximately 10% of Hirschsprung disease patients. In Mikko's presentation, it said 2 to 5%. I think there are figures available from approximately 2 to 15% or something like that. I also think that it's important looking at long-term outcome data to remember that most studies are limited by a small sample size, and also that the time to follow up is quite short. I'll say a few words about these things. It's about mortality, it's about bowel function, it's also about inflammatory bowel disease and growth and nutrition, and also a few words about quality of life. First of all, I think it's important to remember that just a few decades ago, total colonic aganglionosis was a disorder associated with very high mortality. These are data from a systematic review from 1980, covering papers from 1982 to 2012, with in all 36 publications. And dividing that period in two parts, the mortality between 1982 and 1996 was actually over 30%, while it dropped from 1996 to 2011 to approximately 12%. Surely the mortality is lower nowadays, but I think this is still important to remember. Talking about bowel function, I think one of the difficult issues is that there is no consensus on how bowel function should be reported in patients with Hirschsprung's disease, and particularly not in patients with total colonic aganglionosis. This slide is a short summary of a presentation given by Anders Telle-Hoel from Oslo, which he presented at the EUPSA meeting in Athens in September. And it's a review of articles where the authors looked at which questionnaire, which score was used to evaluate bowel function in this population. It's not specifically for total ganglionosis, but it's also patients with other forms of Hirschsprung's disease. And in this study, it was found that almost 50% of the studies reported bowel function according to self-designed questionnaires. The most commonly used score or questionnaire was the bowel function score, which was used in 12% of the cases. And then, as you can see, there is also another few scores or questionnaires that were used with quite low frequency. And on top of this, I think there were 13 or 14 other questionnaires that had been used. And I think this fact makes it all, again, difficult to compare different studies, compare outcomes of different studies. One of the main problems with when it comes to bowel function is the consequence of having done a colectomy, including resection of parts of the ileum, and that's of course frequency and also liquid stools. It's often reported that patients also long-term have somewhere between 3, 4, up to 10 bowel motions per day. What is also very commonly described is, as you see further down, that patients start having more frequent bowel movements at, like for instance in this case, at 5 years of age, but that the frequency drops to 10 or to 15 years of age. So that's very often reported that the frequency gets better with time. What you see on the right-hand side of this slide is data from a recent Dutch study where they looked at the stool consistency. And on the right-hand side, it's rectosigmoid Hirschsprung's disease, and on the left-hand side, it's rectosigmoid Hirschsprung's disease, and on the right-hand side is total colonic aganglionosis. And the darker the color, the more liquid the stools. When it comes to continence, it is a very frequent problem that patients with total colonic aganglionosis have difficulties holding back defecation, and this is reported with various frequencies. Comparing these two studies, where the first one is a Nordic study and the second one is a Swedish study, the figures range from 40 to 70%. In this study, it was also frequent with at least one fecal accident per week. Approximately 20% of the patients had at least one fecal accident per week. And approximately 90% of the patients had increased frequency of defecation, at least bowel motions twice per day. And it's also very obvious that a large proportion of the patients have social restrictions due to their symptoms. Maybe 50% of the patients have social restrictions due to their symptoms. As previously said, bowel function score is one of the most frequently used questionnaires or scores to assess bowel function. And I think you all know that this was described by Mikko's predecessor, Professor Rintala, in the 90s, where 20 is the maximum. A majority of control individuals would have a score more than 17, and 12 to 16 is often described as a moderate bowel function and less than 12 as a poor function. And again, looking at these two studies from the Nordic countries and from Sweden, the median bowel function score was 15 in both these studies. But looking a little bit at the more detailed figures, approximately 25% of the patients had bowel function which could be considered more or less normal, whereas 75% of the patients had a negative impact on their bowel function of their total colonic aganglionosis. This is a study which was recently published from the Netherlands, where rectosigmoid Hirschsprung disease was compared with total colonic aganglionosis with respect to function. And interestingly, it could not be shown in that study that it was more common with fecal incontinence in patients with total colonic aganglionosis, at least not at a significant level. What was on the other hand shown was that liquid stool incontinence was much more frequent in total colonic aganglionosis, whereas, not surprisingly, constipation was much more common in patients with rectosigmoid Hirschsprung's disease. Sometimes there is a little bit of a confusion when it comes to outlet obstruction, which is usually not by definition constipation in patients with total colonic aganglionosis, but outlet obstruction is often defined as difficulties passing stool despite soft fecal continence and or difficulties passing gas. And this is at least to a certain extent, depending on internal anal sphincter achalasia, and it's quite frequent, at least 30 or 40% in different studies report outlet obstruction. I'm sorry. Then Hirschsprung's associated enterocolitis is also a very frequent problem in patients with total colonic aganglionosis, probably more frequent than in rectosigmoid Hirschsprung's disease, and it's often reported to occur in 40 to 50% of patients, but there are figures that are much larger than that. And I think the largest incidence rate of Hirschsprung's associated enterocolitis in patients with total colonic aganglionosis have been reported in those patients undergoing the Lester-Martin extended Duhamel procedure, which is not used anymore. So Hirschsprung's associated enterocolitis is very common. Again, there is a problem with the definition of Hirschsprung's associated enterocolitis. I think many of you are familiar with the Pasteur enterocolitis score, which was based on a Delphi model and a consensus. It was a consensus statement where a score was created where more than 10 was considered to be enterocolitis. This score was slightly modified by Frickman, who considered more than 4 to be equivalent to having enterocolitis. What I think is that in a lot of publications on total colonic aganglionosis, enterocolitis is more or less defined in a more pragmatic way. Often it's defined as on a clinical basis as a combination of diarrhea and or foul smelling stools and fever, and also based on the intention to treat, so need for antibiotic treatment. Another problem which is very common in patients with total colonic aganglionosis is gas incontinence. This is not very frequently reported, but I think many patients really suffer from gas problems. And in the Swedish study, where Pernilla Stenström was the first author, almost 50% of the patients reported frequent or constant problems with gas incontinence or bad smell. So how should the poor bowel function be investigated in patients with total colonic aganglionosis? Of course, good history is crucial to decide what to do. It's, I think, very important to examine the patients meticulously. Often it's a very good idea to do this under general anesthesia. It's important to exclude that there is a stricture that can be treated. It's also important to see that the transition epithelium is intact. There is strong evidence that damaged transition zone epithelium or a damaged dentate line is associated with fecal incontinence. It's usually recommended to do a contrast enema. On a contrast enema, it's possible to see if there is a bowel dilatation or not, and it's maybe also possible to see if there is a twisted pull-through. Patients with significant poor bowel functions should undergo repeat rectal biopsies to exclude residual or acquired aganglionosis or a transition zone pull-through. In some centers, anorectal manometry is used frequently in these patients. We don't do that very much in Stockholm. And Mikko described that some patients have more severe bowel dysmotility, and usually those patients should undergo small bowel biopsies to see if there is a morphological correlate to their dysmotility. So how should patients with poor bowel function be managed? Well, for fecal incontinence, usually, of course, medical management is the first line. Many or most of these patients benefit from having loperamide. We quite frequently use water-soluble bulking agents, which I think often have quite a good function on the liquid stools. But it's also important to remember that at the end of the day, some of these patients with intractable fecal incontinence benefit from having a permanent stoma. Hirschsprung-associated enterocolitis is treated in the same way in patients with total colonic aganglionosis as in rectosigmoid Hirschsprung's disease. We usually use metronidazole first, usually for just a few days, 5 to 7 days, and in patients whose enterocolitis recur, we usually keep the metronidazole for longer periods of time. Many of these patients with particular recurrent enterocolitis need rectal decompression. When it comes to probiotics, there is no strong evidence that probiotics makes a big difference. I know that some centers use that, but there is no strong evidence for that. When it comes to outlet obstruction, as Mikko showed, many patients benefit from having intersphincteric botulinum toxin injections, and that could be recommended both for patients with persistent outlet obstruction and for patients with recurrent enterocolitis. And then, of course, there is a role for pull-through redo procedures for patients who are shown to have residual aganglionosis, a transition zone pull-through, a stricture that does not respond to dilatations, or a twisted pull-through. When it comes to botulinum toxin injection treatment, in the Nordic study that you have heard of before, 25% of the patients were actually treated with botulinum toxin injections. And I think these are figures that are common in more recent publications, in older publications. There are other things mentioned like sphincter myectomy, which is very rarely done today after everybody, I would say, started using Botox instead. And what about the indications for treatment? As I said, it's a mixture of outlet obstruction and recurrent enterocolitis. Some of the patients have both. We looked at the Botox injection treated patients in Stockholm a few years ago, and in that study we couldn't show that the length of a ganglionic segment could predict the outcome of the botulinum toxin injections. The study was not designed for that, and the sample size was quite small, but we couldn't show that length of a ganglionic segment predicted the outcome of botulinum toxin. As previously said, some patients benefit from having a permanent stoma. As Mikko said, I think particularly patients with aganglionosis extended proximally into the ileum or even jejunum. Also, some patients with intellectual disabilities benefit from having a permanent stoma. And it has been reported that 5-6% of patients up to 26% of patients need a permanent stoma or benefit from a permanent stoma. And the indications are mainly intractable fecal incontinence and severe recurrent enterocolitis. Mikko also mentioned the association between Hirschsprung's disease and inflammatory bowel disease. And in recent years, it has been clearly shown that the risk of inflammatory bowel disease, particularly Crohn's disease, is increased in individuals with Hirschsprung's disease. And when we looked at the Swedish patients with IBD associated with Hirschsprung's disease, 22 of the patients had total colonic aganglionosis. I'm not sure if that means that the risk is higher in patients with total colonic aganglionosis. This study was not really designed to look at that. And in patients who have a suspected inflammatory bowel disease, they should, of course, be monitored with fecal calprotectin and undergo ileoscopy. Then the next issue, which Mikko also mentioned or talked about, is growth and nutrition. And in the Nordic study, a third of the patients needed parenteral support during the first few years of life, whereas almost 50% of the whole patient group needed oral nutrition support. That was short term, but also at follow-up, a significant proportion of the patients need nutritional support, some of them orally, some of them parenterally, some of the patients had a gastrostomy for nutritional support. And despite the nutritional support, many of the patients reported growth that was not adequate. In the Nordic and Swedish studies, a proportion of patients reported low weight for age, a proportion of patients were short for age, and some patients had low body mass index. This was looked at in a German study where even 55% of the patients had insufficient growth. And I think this is more recognized in more recent studies. In older studies, this is not as frequently reported, although the rates are lower. In this study, for instance, from 2008, it was only 5% who reported failure to thrive. There is quite a nice study from the 90s looking at the metabolic problems with total colonic aganglionosis, clearly showing that it's more common with iron deficiency, with vitamin B12 deficiency, and I think that should be monitored regularly in these patients, and many of these patients need supplementation. It's also very important to follow or to monitor sodium deficiency. You always do that in urine, and these patients almost always need sodium chloride supplementation. Looking at quality of life, there are only a few studies assessing this. This is a Dutch study which reported health-related quality of life, where they looked at domains that were negatively affected and described that general health perception was worse in TCA patients compared to the normative sample, and that was the case also for physical functioning and for bodily and pain discomfort. Also looking at disease-specific quality of life, total colonic aganglionosis patients reported more diarrhea, more physical symptoms. They also reported more emotional functioning problems, and it was obvious that emotional function problems had a larger or greater impact on the quality of life than the other two. So to conclude, it's very clear that total colonic aganglionosis has a negative long-term impact on bowel function and growth, and also on quality of life. And I think the most important take-home message is that all these patients need a multidisciplinary long-term follow-up. And I think it's also very, very important that these patients need to be transitioned to adult care properly. Thank you very much.
Yes, thank you very much, Tomas and Mikko. There are already a few questions. I don't know if you can see them or if I need to read them out loud for you. Mikko, can you see the questions that were sent to you?
Well, I don't think I can.
Okay.
The only thing in chat is your message.
Yeah, okay. Well, then I will read them out loud. I hope that I address them to the right presenter. Otherwise, the other one can just answer. The first is for Mikko. It's from Roni's Fire. My pathologist always says that biopsy features in small intestine is more difficult than in colon. Do you have any remarks about this?
Yeah, I perfectly agree, and that's why what I said is that I think it's, to be on the safe side, it's probably wise routinely also let the pathologist use all the immunohistochemical stains and to do the histopathological assessment with time and to reach as sort of a confirmative conclusion as possible. But it also gives a possibility for a pathologist to seek consultation and other opinion. But I perfectly agree that it's much more challenging also for pathologists to sort of assess the aganglionosis, but especially the transition zone in the small intestine. So I mean, if one trusts or thinks that is able to do the pull-through based on frozen sections, then you have to be very, very sure that you have extremely experienced and confident pathologists to give that information.
Yeah, thank you. Roni also asked, what is the goal of mucosectomy?
Goal of mucosectomy? Well, in a way, I think the part of the operation is to get the anastomosis in a way to low enough. So the part where you start the mucosectomy, you're going to replace with in this case, with the pull-through of small intestine. Mm-hmm. So it's of course it's not as in, for example, in ulcerative colitis where you want to remove the diseased or potentially or part of the mucosa which is diseased or potentially will get disease. That's not, of course, required in Hirschsprung's disease, but it's part of the seeking to get the anastomosis low enough. So in that sense, you don't want to put the anastomosis to the too high. And we start the transanal mucosectomy about 5 to 10 millimeters above the dentate line, and do it also in the same level if we do transabdominal mucosectomy as in classical Suave operation.
Great, thank you. There's another question from Farid, maybe a short question. What is the incidence of TCA in siblings?
TCA in siblings. I don't have any exact figures. All I know that I have treated 2 families with the brothers and sisters, but I don't have any figures. Do you, Tomas, know any?
No, I just have these families as well with more individuals than one. I don't have an exact figure. I mean, definitely having Hirschsprung's disease in a sibling is much more common if one child has total colonic aganglionosis.
Yeah, but it's if you look at the whole incidence of genetic disease. I think it's in a Nordic study. It was only, you might say, only about 20%. So even in this patient population, but of course it was part of the patients were treated several decades ago. So maybe at that time the genetic diagnostics were done so routinely as nowadays. So, but certainly is, especially in TCA, it's very important to have a full genetic workup done as part of the diagnostic procedures.
Yeah, that's clear. Another question from Farid is, why do we wait until 3 years of age to close the ileostomy?
No, 3 months. I'm sorry if I was unclear, but in those patients where the aganglionosis it is limited to less than 20 centimeters of distal small bowel, in those patients we close the stoma 3 months after the actual pull through, and the median age of pull through in those patients is 2 months. So they are about 6 months of age when we close the stoma. But on those patients where the aganglionosis extends to close to 50 centimeters, they are prone to have more severe and long-lasting diarrhea because of a more extended ileal resection where, for example, bile acids are absorbed. And in those patients, it's probably wise to wait at least for the stoma closure until they are about 2 years of age or older. Or I think it's quite good idea to also measure the stomal output. And if that's as reported in Paris paper below 30 milliliters per kilogram per day, then you can assume that the diarrhea after pull through is not too severe.
Okay, thank you. Farid has a lot of questions. Another one, do we find skip area in TCA?
I think it's extremely rare. We actually have a patient with total colonic aganglionosis who had an area in the rectosigmoid which was ganglionic, but it's extremely rare.
Okay. Well, there's another question about the doses. What doses are used with the Botox?
We usually, for children more than 10 kilograms, use 100 units, which I inject in the 4 quadrants, so 25 in each quadrant. For babies or for infants less than 10 kilograms, I usually use 10 units per kilogram. Usually it's quite rarely done in the really small babies, but I usually use 10 kilograms or 10 units per kilogram in small infants, but above 10 kilo, 100 units. I think you do something similar, Mikko.
Yeah, and in the older children, our maximal dose is 200 units. If they're bigger children, so then we would give 50 units in 4 quadrants in those. But for the smaller baby, just as Tomas said, yeah.
About the Botox, someone asked, Botox have a transient effect? How long can it be used?
Well, it's correct that Botox has a transient effect. Usually it works for 3-4 months. Usually it's necessary to repeat this several times, but with age, I think many of these patients can be weaned off having regular Botox injections, and I think that's because for some reason the internal anal sphincter achalasia gets less of a problem, or children learn how to overcome the achalasia in some way. But I think we have patients who need regular Botox injections for several years, but at the end of the day, usually you can extend the intervals between injections and stop repeating the injections.
Thank you. There's another question from Mikko from Francesco Facciatileo. Can you tell us more about the teduglutide usage in TCA patients?
Well, of course, it's as you all know, it's usage in children in general. It's quite recent, and we are fortunate in right now that we're able to use that in children with intestinal failure, and we have quite recently started the therapy in 2 of these patients, and like I said, that the response in the other one of them is quite nice and good. So I think not only teduglutide, but also there are much more novel endocrine hormone preparations most likely coming during the coming years, and I think that would be, or there's a potential that those medical therapies will provide significant, or they have a potential to provide significant advancement in treatment in those children who have very extended aganglionosis, or those patients, as I showed, let's say less than 1 meter of proximal ganglionic small bowel. So then probably some of them could be, even though they are left with permanent jejunostomy, still some of them could be weaned off PN, or at least we could significantly decrease the PN requirement in those patients. So I think that's something which is very sort of interesting and potentially promising in those patients.
Okay, thank you. Well, there are many questions, so I'll just do 2 more, and the rest I will send to you by email. I've got a question from Alba Sanchez Galan from Spain. In case of a massive Anglo-Glynosis where the stomach is included, do you recommend enterectomy of the colon and small bowel?
Well, I think that in those, of course, that's very sort of a extreme case, but I think like I said, in those cases where if the aganglionosis is in the area of, we have had 1 patient where it's in the pylorus, and in that patient we left 40 centimeter of aganglionic jejunum distal to ligament of Treitz, because if you do total enteroctomy, then you know that the patient is most likely will suffer very rapid a deterioration of liver function, and of course will have extremely high output enterostomy, and will be difficult to manage to be able to have anywhere near stable fluid and electrolyte balance and so on. So I would always leave at least the 40 centimeters of the proximal jejunum, and then combined that with myectomy if needed, if there's still significant obstructive symptoms. But these are, of course, patients which should be treated with treated in collaboration with a transplantation center from very early on, because it's of course clear that those patients will not wean off, and they are in very high risk to develop life-threatening complications of intestinal failure very early on.
Okay, and then the last question from Lucas Matthijssen. What is the frequency of pouchitis in your patients? How do you treat these nowadays, and do you have tricks or tips to prevent these?
That's a very good question, because when you do J-pouch ileoanal anastomosis, it's sort of whether the patient is actually having pouchitis or enterocolitis. It's a matter of question. Does it really matter which thing is going on? I don't know, but we have looked at that in our own material a few years ago, and also the calprotectin levels, and it seemed that the pouchitis or enterocolitis episodes in Hirschsprung's disease patients were a little bit less what occurred in our patients with the ulcerative colitis and having undergone the same operation. We treated with metronidazole, and I have to say that none of our Hirschsprung's disease patients have developed such a severe repeated pouchitis as some of the ulcerative colitis patients do. So that really hasn't been a major issue. I think the bigger issues early on, just what Tomas mentioned about the obstructive symptoms and defecations, and that's very common in the early phase after operation.
Okay, well, thank you very much. It's already 7:10, so we need to finish the webinar. But thank you all for joining, and thank you, Mikko and Tomas, for the very interesting talk. The webinar has been recorded and will be available on both our GoToWebinar platform and our YouTube channel. I will send you all the links tomorrow, and the links for previous sessions are on our website. You can subscribe to our YouTube channel, and there you can easily find the past webinars. Finally, we will send a survey immediately after the session, and we would be very grateful if you could spend a few minutes filling it in to help us continuously improve further session. And then for now, I